Hi, my name is Shay Elliott, and I'm going to be discussing complications of the late preterm infant today. I've been a NICU nurse for almost 9 years, and I'm in school completing my doctorate to be a neonatal nurse practitioner at Creighton University. My second child is pictured here and was born at 34 weeks with a birth defect and had an extensive stay in the NICU. I'm very passionate about what I do, and I hope that you enjoy this presentation and learn some valuable information regarding care for the late preterm neonate. I would also like to recognize Sherry Kimmy for her contribution to much of the information in these slides. Thank you for listening, and I hope you enjoy. Objectives for this PowerPoint are the healthcare professional is able to self-report at least 3 potential complications of the late preterm infant. Healthcare professionals are knowledgeable about best practices for managing the use of continuous positive airway pressure, or CPAP. Healthcare professionals are able to evaluate basic neonatal hematology and lab values, and healthcare professionals are able to identify feeding challenges in the late preterm population. As an overview, I will be discussing the definition of the late preterm infant, talk about delayed transition to extrauterine life, respiratory distress, thermoregulation, hypoglycemia, hyperbilirubinemia, feeding immaturity and related problems, sepsis, and hematology and basic lab interpretation. The late preterm infant includes any infant born between 34 and 0.7 weeks and 36 and 6/7 weeks gestation. There's approximately 350,000 late preterm infants born each year, which comprises about 70% of all preterm infants. They are prone to issues related to prematurity, such as respiratory distress, hypothermia, hypoglycemia, hyperbilirubinemia, feeding intolerance, and immaturity. They are 3.5 times more likely to suffer from one of these problems than term infants. Late preterm infants are also at risk for increased mortality, especially when compared to their term infant counterparts. They have 6 times the risk of early mortality between days of life 0 and 6. They have 3 times the risk of late mortality, which are days 7 to 27 of life. They have 2 to 3 times the risk of death due to preventable causes, and they are 2 times the risk of having SIDS, or sudden infant death syndrome. Here's a nice picture that depicts critical periods of brain development in the neonate. Late preterm infants are born with only 65% of term infant brain development. The brain is rapidly growing in the 3rd trimester. Brain growth is influenced significantly by the fetus's experience in the womb, but for us, their brain will be influenced by their NICU experiences. From about 24 to 40 weeks, they are forming sulci, or the grooves, and gyri, or the ridges, of their brain. This is where the higher level of processing occurs, such as memory, language, visual perception and reasoning, and information processing. At this time, individual neurons begin to mature and organize themselves and interconnect. Impulses pass to one another. This is also when myelination begins, which is the white fatty substance in the brain that is developed, which is the protective coating. Think of this like wiring of a house, where the rubber coating is over the wires. They would short out all the time. Toxic stress will have a potential detrimental effect on this process. Disorders are seen when these processes are disrupted. It's important to keep in mind that for preterm infants, negative experiences have a greater effect on their psychologic state and processes than do neutral or positive experiences. So any negative feedback that they get in the NICU, those are the experiences that really stick with them and turn into negative outcomes. So what is thermoregulation? Thermoregulation is a balance of heat loss, heat gain, and heat production. We want our infants to maintain a neutral thermal environment. This is when the infant's metabolic rate and oxygen consumption are at a minimum, while normal body temperature is maintained. We want the least amount of energy that is required. Babies use calories to grow, and there's a narrow range of temperatures that provide the neutral thermal environment. Temperatures that are too high or too low will add to their stress and increase their metabolic rate. This is when babies tend to lose weight due to all the calories they burn from trying to stay warm. Late preterm infants are at increased risk for hypothermia. Reasons for this are because they have less subcutaneous fat and a thin epidermis layer. They have decreased brown fat storage for thermogenesis. They have a disproportionate body mass to surface area ratio, and their tone is less developed than in term infants. They have a more extended posture. They also have decreased vasomotor control. So why is thermoregulation so important? Infants who experience cold stress have increased morbidity and mortality. Effective thermoregulation reduces the risk of hypothermia and the potential side effects of cold stress in the neonate. Infants have three main mechanisms of physiologic responses to cold stress, including vasoconstriction, metabolism of brown fat, and increased muscle activity and flexion or tone or posture. Activity is increased to generate heat, and the baby flexes itself to decrease the body surface area to prevent further heat loss. Untreated hypothermia results in an increase in the metabolic rate and oxygen consumption in the neonate. Hypothermia is preventable, which is the good news. So this just is an overview of their mechanisms of heat production, which are metabolic processes, voluntary muscle activity, and non-shivering thermogenesis. Metabolic processes include heat generation by glucose, fats, and proteins. Voluntary muscle activity includes postural changes, restless movements, which are limited use to the newborn in generating heat. And then they can do what's called non-shivering thermogenesis, which relies on the metabolism of brown fat, which is initiated in the hypothalamus, causing a norepinephrine release at the site of brown fat. Brown fat is located around the infant's kidneys, adrenal glands, mediastinum, subscapular areas, axillary, and nape of the neck, and it is accumulated mainly in the last part of the third trimester. It accounts for 2 to 7% of a term infant's total body weight. Brown fat cells generate more energy than any other cell in the body and produce heat in core regions of the body. When the neonate is exposed to cold stress, norepinephrine is released into the endings of the nerve where it is metabolized. This process is referred to as non-shivering thermogenesis. So here's a good picture that depicts the what happens to the neonate when they undergo cold stress. Cold stress is related to the infant's attempt to increase their core body temperature. It results in altered neurological status, a lower heart rate, hypoglycemia. It can cause lethargy and decreased interest in eating and respiratory distress. So when there's cold, there's increased oxygen consumption, which leads to an increased respiratory rate or tachypnea, peripheral vasoconstriction to conserve heat, pulmonary vasoconstriction, a decreased oxygen uptake by the lungs at that point, which leads to a decreased oxygen delivery to the tissues, which then causes an increase in the anaerobic glycolysis. And this all results in a lower PO2 and pH, leading to metabolic acidosis. So the four main modes of heat loss in the infant are evaporation, which is heat lost as a liquid as it changes to vapor, conduction, which is heat lost from one solid object to another solid object which is in direct contact with the neonate, convection, which is heat lost from body surface to surrounding air via current, and then radiation, which is heat lost to cooler solid object which is not in direct contact with the body. Some symptoms of hypothermia you might see in the late preterm infant include apnea and bradycardia spells, hypoglycemia, hypotonia, hypoxemia, feeding intolerance, an increased metabolic rate or weight loss, if it's for an extended period of time, metabolic acidosis, poor weight gain, pulmonary vasoconstriction or PPHN, which is the constriction of those vessels in the pulmonary bed, respiratory distress, and a weak cry or suck. So prevention of hypothermia is key. You want to keep the environment warm. Make sure that the radiant warmer is pre-warmed to 100% output before the infant's born. Keep the infant under the radiant warmer for initial resuscitation. Dry them well and apply a hat. Later, you want to keep the infant dressed and swaddled when not doing a skin-to-skin with one of the parents. You only want to bathe them after about 24 hours of life, and that's only if the temperatures have been stable. And then anytime you're bathing them, it's important to do quick swaddled tub baths. We want to feed each infant every 3 hours or more frequently to avoid hypoglycemia and extended periods of fasting. As far as bathing, newborns are the most vulnerable in the first 24 hours after birth. They have to quickly adapt to extrauterine life through their thermoregulation and energy metabolism mechanisms. Early initiation of a newborn bath can increase this vulnerability, which can result in hypothermia, hypoglycemia, increased infection rates, and also interrupted breastfeeding. So many late preterm infants have issues with feeding immaturity. Potential problems you may encounter are immature suck, swallow, and breathe, and discoordination of that process. Longer feeding times and shorter intervals between feedings. They have immature musculature just due to less tone, and a weak suck. Late preterm infants should not be compared to full-term infants in mature sucking behaviors or sufficient milk transfer until at least 40 weeks corrected gestational age. It's really important to make sure these infants are latching well and transferring milk well when they're breastfeeding. Some interventions that are helpful for immature feeders include assessing the entire feeding every time the infant feeds. You want to make sure that they have a coordinated suck, swallow, and breathe. Feeds shouldn't take longer than 20 minutes. The infant should not become tachypnic or apneic with feeds. They should not have any change in color or choking spells. It's important to support breastfeeding mothers, especially if they are first-time mothers or first-time breastfeeders. It would be awesome to get a lactation nurse involved if there is one available. We want to supplement some of these infants as needed, especially when mom's milk supply is low. And closely monitor weight gain or loss with daily weights. They should not have a greater than 10% loss of weight from birth weight. So some of the feeding challenges you might encounter, which I kind of mentioned, for breastfeeding challenges, there is an increase in breastfeeding non-initiation rates in late preterm infants. There's a decreased breastfeeding initiation rate within the first hour after birth, a decreased exclusive breastfeeding rate at discharge, a decrease in continued breastfeeding rates after 10 weeks, and then poor feedings can result in, like I mentioned, poor weight gain, dehydration, inadequate breast stimulation and maternal milk supply, and this dehydration can lead to hyperbilirubinemia, hypoglycemia, and sometimes even hospital readmission for treatment of either dehydration or hypoglycemia or hypobilirubinemia. So as far as supporting our breastfeeding mothers with their late preterm infants, we want to provide immediate and uninterrupted skin-to-skin until after the first breastfeeding. We want to help them learn how to hand express within the first hour of delivery, or at least establish breastfeeding or pumping. Monitor and document feeding frequency. Make sure we're limiting their attempts at breast to 10 minutes so they don't tire themselves out and burn more calories than they're consuming. Make sure they have a lactation consult within 24 hours of life, and helping mom utilize a nipple shield if there's an ineffective latch or milk transfer. And then if we're worried about the amount of milk that the infant is transferring, we can initiate pre- and post breastfeeding weights as needed. It's also important to encourage these moms to pump after each breastfeeding at least every 3 hours to help establish her milk supply until the infant is more mature and can take an entire feeding from the breast. This may take several weeks to months. It's important to have them use a hospital-grade electric pump, which will help eject their milk properly. We want them to pump early and pump often. Within 1 hour of birth is ideal. Less than or equal to 2 hours after a vaginal delivery, or less than or equal to 4 hours after a C-section. And obviously, the earlier the better if they're not able to put the baby to breast. We want to do hands-on pumping and hand expression after pumping. So as far as the nursing management, while these moms are feeding, we want to observe every feeding every 3 hours, observe and document feeding cues every 3 hours, supplement as needed if medically indicated by breast or bottle. We want to make sure feedings are paced and the baby's not spilling a lot of milk or choking or having coordination issues. We want to do ongoing monitoring and documentation of their voids and stools to make sure they're having enough output. And then, like we mentioned before, we want to make sure we're doing daily weights and monitoring weight gain and loss and avoid excessive weight loss. Breast milk provides long-chain fatty acids, which are critical for the development and protection of the immature brain. As a side note, late preterm infants should not be fed by cup, finger, or syringe, as they need to prove that they can take adequate volumes from breast or bottle prior to discharge. Late preterm infants should lose no more than 3% of their birth weight by 24 hours and no more than 7% of birth weight by 72 hours as kind of a guideline for weight loss. So hypoglycemia, this is kind of a touchy subject as there's not a true definition of what constitutes hypoglycemia, but the American Academy of Pediatrics defines hypoglycemia typically as less than about 40 for a blood glucose level. A lot of infants will have transient asymptomatic neonatal hypoglycemia in the first 2 days of life. This is especially prominent in the first 1 to 3 hours after birth when they have kind of this transitional period with their glucoses. 15% of all newborns require specialized treatment for hypoglycemia. Those that are especially at risk are babies who are small for gestational age, large for gestational age, preterm or late preterms, growth-restricted infants, infants with poor APGARs at 10 minutes of life, among other risk factors. Many of them will require IV glucose in a NICU admission for treatment of their hypoglycemia. The first intervention is usually increased in frequent feedings. 50% of all infants with identified risk factors end up in the NICU for IV glucose, and 60% of preterm infants need IV glucose for treatment of their hypoglycemia. Hypoglycemia leads to increased energy demands related to hypothermia, sepsis, hyperinsulinism, especially if they're infant of diabetic mothers, or it obviously occurs more often in late preterm infants because it's related to a reduction in glycogen stores, delayed gluconeogenesis, an insufficient metabolic response to abrupt loss of the maternal glucose supply, increased energy demands for growth, and an immature GI system. And then they often have, like we talked about, feeding issues and inadequate enteral intake. So things you can do for hypoglycemia prevention. You want to identify infants who are at risk. There's maternal risks such as gestational or diabetes. Gestational diabetes or any type of diabetes, especially those who require insulin to control their diabetes. Pregnancy-induced hypertension, maternal obesity, use of tocolytics for preterm labor, late antepartum or intrapartum administration of IV glucose, a difficult or prolonged delivery, non-reassuring fetal heart pattern. And then neonatal risks, like I kind of mentioned, include infants who are IUGR or growth restricted, twin gestation, they tend to be smaller, 5-minute APGAR scores less than 7, hypothermia or temp instability issues, sepsis, respiratory distress, anything that utilizes extra energy, and then polycythemia and hyperviscosity. Infants at risk for hypoglycemia are also at risk for poor feeding. They tend to be a little bit sleepier and less interested in eating, and they may be unable to safely or effectively feed. So we want to promote thermoregulation in these babies, feed them within the first hour after birth. We want to check a glucose 30 minutes after their initial feeding and within 1 hour of life. We want to feed them at least every 3 hours, monitor their feedings to ensure feeding effectiveness, check before feed glucoses every 3 hours for at least 24 hours, and observe for signs and symptoms of hypoglycemia, such as jitteriness and some other things that we'll talk about. Hypoglycemia nursing management. Anytime you have a glucose less than 40, it needs to be treated. We follow the hypoglycemia algorithm that the institution has in place. At our institution and many others, it requires giving a dose of glucose gel and then supplementing with a feeding of breast milk or formula immediately after. At Women's Hospital, we use 15 mils via bottle or gavage if they're not able to breastfeed effectively for 10 minutes. And if they are bottling and do not take the full volume, then the remainder has to be gavaged. And then these infants, once they have hypoglycemia, they must be supplemented for the remainder of their hospitalization until their first outpatient visit. They must breastfeed effectively for 10 minutes, supplement with a bottle after every feeding. A blood sugar less than 40 requires a mandatory volume of 15 mLs of formula or breast milk. And if their blood sugars are greater than 40, the feedings are infant-driven, and then infants may go back to breast after they are supplemented, if they desire. Like I said, signs and symptoms of hypoglycemia sometimes are kind of non-specific, but often these kids will become jittery. They can become kind of lethargic. They can develop apnea, cyanosis. They might have low tone, be hypotonic, have poor feedings, and disinterest in feeding. If it gets really low, they can have seizures. They're more prone to hypothermia. They can become tachycardic and tachypnic and develop respiratory distress, and they may have an abnormal cry. So some important interventions for hypoglycemia. We definitely want to keep these infants warm so they're not burning extra energy to stay warm and developing hypoglycemia. We want to check their blood sugar within an hour after birth and continue to check glucoses until they're stable. The duration of glucose checks may vary by institution. We want to feed them at least every 2 to 3 hours, supplement them as needed, give glucose gel when indicated, and if need, they can have up to 2 doses of glucose gel at Women's Hospital. But after that, if they're still having low blood glucoses, then they need to be transferred to the NICU for IV glucose bolus and a continuous infusion of dextrose. So now we're going to move on and talk about hyperbilirubinemia. This is caused by the byproduct from the breakdown of red blood cells via hemolysis after birth. This is a normal process in all infants. They have extra red blood cells in circulation. They might have bruising from delivery, and they might have a cephalohematoma, which is basically a pocket of blood that needs to be reabsorbed. A lot of them have polycythemia if they're growth restricted or infants of diabetic mothers. Hyperbilirubinemia can be exacerbated with dehydration or poor feeding. It can be pathologic if there's Rh or ABO incompatibility present, and infection can also cause destruction of red blood cells, so that's something to look out for. Some of the signs and symptoms of hyperbilirubinemia might be a yellow or orange discoloration of the skin and the sclera of the eyes. Usually jaundice will progress from head to toe as the level rises, so it'll start in the whites of the eyes and the head and kind of move down as the level gets higher from head to toe. These infants might display increased lethargy, decreased interest in eating, and they may have decreased voiding and stooling. Hyperbilirubinemia commonly occurs in newborns greater than 24 hours of age, and it's always pathologic if their jaundice appears when they are less than 24 hours of age, or usually also pathologic after 2 weeks of life. If it goes away and comes back, or they never had jaundice and they all of a sudden develop jaundice around 2 weeks of life or greater. And then again, this hyperbilirubinemia is exacerbated in the late preterm population. So the cause needs to be investigated. Anytime you have a jaundice baby, you want to obtain a total and a direct bilirubin level. These babies have decreased conjugation due to their prematurity by the liver. They have a decreased GI motility and stooling, and they're less, obviously, like we talked about, they're less efficient at breastfeeding and eating and more prone to dehydration. So some tests we would want to order to rule out some things is a Coombs test, a direct antibody test. Infants who are positive have Rh or an ABO incompatibility with their mother. So oftentimes it's moms who are Rh negative and babies who are Rh positive, or a mom who is O and the baby is A or B blood type. And this is usually in a subsequent pregnancy, not the first pregnancy. And with the O or with the AB incompatibilities, B is bad, but A is awful. So A incompatibilities are usually cause worse jaundice and hyperbilirubinemia. But Rh incompatibility is usually worse than ABO incompatibility. So we want to be extra vigilant about assessing for jaundice and obtaining bilirubin levels in these kids. We want to obtain their first serum bili level or a transcutaneous level if they're greater than 35 weeks at 24 to 48 hours or sooner if they look very orange. Usually hyperbilirubinemia peaks at days of life 3 to 5, but it can be a little bit later in late preterm infants, sometimes up to day 7. And then we want to follow the AAP guidelines for phototherapy, which I'll show you a graph later on in the presentation, but it shows the infant's hours of age versus an acceptable level of bilirubin for their gestational age and risk factors. So here's the graph I was talking about, and infants are categorized based on how old they are and what other risk factors they have compared to their total bilirubin level. Some of the risk factors might include isoimmune hemolytic disease, like we talked about, Rh and ABO incompatibilities, G6PD deficiency, asphyxia, significant lethargy, temp instability, sepsis, acidosis, or low protein or albumin levels less than 3 if they've been measured. So infants at higher risk are the bottom, the bold line, and then as you move up the medium dashed line is infants at medium risk for hyperbilirubinemia, and then the top line of the ticks are infants at lower risk, and usually older gestational and well infants. So interventions for hyperbilirubinemia, kind of mentioned these already, but you want to check the first bilirubin level around 24 to 48 hours of age. You want to make sure these infants are hydrated and stooling. Bilirubin is eliminated via urine and stool. We want to make sure they're taking frequent and adequate feedings, and these infants may need to be supplemented with formula. In some cases, they even need some IV fluids. And we want to check some infants require NICU admission for severe hyperbiliry with multiple banks of phototherapy. And in severe cases, the infant may require IVIG and or an exchange transfusion to prevent kernicterus, which is neurological damage from bilirubin crossing the blood-brain barrier. Phototherapy helps convert bilirubin into a water-soluble form, which can be more easily eliminated by the GI system. And then the IVIG coats red blood cells to help protect them against hemolysis. And then exchange transfusion is when the infant's blood with the high bili levels is exchanged for donor blood to help decrease the bilirubin level. And that definitely requires a NICU admission. So now let's talk a little bit about delayed transition. This is not specific to late preterm infants, but more common than in term infants. There's a lot of lung changes that are required when infants are born and the cord is clamped and they take those first few breaths. If their lungs remain kind of clamped down with high pulmonary vascular resistance after birth, they can develop issues with persistent pulmonary hypertension. Sometimes late preterm infants, the ductus won't close, their ductus arteriosus won't close right away, so they might have some shunting of blood from the systemic system to the pulmonary system. And if they do have delayed transition and their lungs aren't oxygenating or perfusing well, they can have symptoms such as low oxygen saturations, a difference between pre- and post-ductal oxygen saturations greater than or equal to 5 to 10%. They might show signs of respiratory distress, such as retractions, tachypnea, grunting, nasal flaring, and cyanosis, and they may need supplemental oxygen or even higher levels of respiratory support. So some interventions to help prevent or lessen the effects of delayed transition. We always want to do resuscitation in the delivery room following the NRP guidelines. We can utilize CPAP or continuous positive airway pressure for infants with spontaneous respirations with grunting or increased work of breathing. We want to provide them with supplemental oxygen using a blender to keep oxygen saturations greater than 90% by the time they reach 10 minutes of life, and we want to titrate oxygen slowly. We want to minimize stimulation to these infants, keep them thermoneutral, and avoid hypoglycemia. We want to consider the need for transferring these infants to a level 3 NICU if they have persistent respiratory problems or worsening of respiratory problems after the first few hours of life, or if they're requiring significant oxygen levels to maintain their SATs greater than 90, or if they become ill-appearing. We also want to consider other causes of respiratory distress. And as I said, respiratory distress symptoms are usually grunting, retractions, or like you'll see babies pull the muscles between their ribs and below their ribs to help, they use their accessory muscles to help them breathe when they're working hard. And then nasal flaring to help keep their airway patent, and they might have cyanosis or bluing of their mucous membranes. So what is CPAP? CPAP is continuous positive airway pressure. It is intended to maintain end expiratory pressure and prevent alveolar collapse and increase the infant's functional residual capacity, or the amount of air left in the lungs after exhalation, and which helps keep the alveoli from collapsing when they exhale and decreases their work of breathing. It's pretty similar to positive end expiratory pressure, or PEEP, if you've ever heard of that. Considerations for CPAP. You want to make sure, like I said, there's an oxygen blender so you can titrate the appropriate amount of oxygen to maintain their sats within the targeted range. You want to make sure you have the appropriate sized mask or prongs or nasal cannula to deliver the CPAP through. The nasal prongs are usually hooked up to a circuit that's connected to the ventilator for prolonged delivery. And the mask should fit snugly from the bridge of the baby's nose to the base of their chin. And anytime you put them on a extended delivery of CPAP, you want to make sure that you monitor their nares and nasal septum closely for breakdown and make sure there's some sort of a protective barrier, such as duoderm, or there's sometimes little foam barriers that you can put between the cannula and their nose. For these infants, we want to start them on an initial setting of a PEEP of about 5 or 6 usually, and always use the lowest amount of oxygen needed. These infants will likely need a chest x-ray and a blood gas, especially if they continue to require CPAP or their respiratory status worsens. They might have what we call respiratory distress syndrome, which is a surfactant deficiency. This is especially prominent in the preterm and late preterm population. They could also have other pathology that we'd want to rule out, such as a pneumothorax. So that would be an important reason to maybe obtain an x-ray. And then, like I said, nursing management, proper fit of the mask or cannula, and making sure we're protecting their skin and their nasal septum. I've seen some kids who have been on CPAP cannulas or the CPAP mask here in this picture on the left that have had excessive septal or nasal breakdown, sometimes as bad as requiring plastic surgery to repair it. So we don't want to let these kids have skin breakdown. So be very vigilant about assessing their nose and their nasal septum and protecting their skin with a barrier of some sort. So this is a CPAP mask on the left, and it can be delivered via a little mask that fits around the nose or little prongs that fit in the nares. And then the RAM cannula is the one I was talking about, which is hooked to the ventilator, and the prongs go into the nose. There's some different sizes of prongs that fit different sizes of neonates. So now we're going to talk about sepsis a little bit. Sepsis occurs 3 times more frequently in the late preterm infant. It's an impaired cellular response, and it can be, sometimes it's hard to differentiate between infection and sepsis, and there's many different pathogens that can cause sepsis. Late preterm infants are more at risk because of the number and the inefficiency of their white blood cells. Preemies less than 2 kilos have less bactericidal capacity than full-term infants. They have less antibody production. The killing power in stressed infants is decreased. Their levels of complement, fibronectin, and cytokines are decreased, as well as their levels of IgA, IgM, and IgG. Sepsis is a generalized bacterial infection that has been documented by a positive blood culture during the first month of life in an infant who is also clinically ill. Sepsis is the presence of pathogens and or their toxins in the bloodstream versus infection, which is pathogens in or on the body, such as pneumonia, UTI, meningitis, or amphilitis. Different organisms that usually cause sepsis in neonates. The number 1 is group B strep, The number 2 is E. coli. And then other common ones are strep, staph aureus, including MRSA and MSSA. A lot of gram-negative bacteria, Enterobacter species, H. influenza, and Listeria monocytogenes. So a tool that a lot of facilities are using now is the Early Onset Sepsis Calculator, which is the Kaiser calculator, which is a tool that helps determine the risk of sepsis in an infant born equal to or greater than 34 and 0 weeks of life. And this is to help promote proper treatment of neonates who are at increased risk for sepsis, and to also help decrease unnecessary use of antibiotics, sort of helping with antibiotic stewardship. So as far as the signs and symptoms of sepsis, it's kind of an all or nothing thing. There's no specific signs. It's more of a non-specific thing. The baby is just not doing well, or there's subtle changes in color, tone, activity, or feeding. There's no single set of criteria that's reliable symptom-wise in diagnosing sepsis. Oftentimes, they'll show CNS symptoms such as irritability, lethargy, jitteriness, tremors, seizures, coma. They might have a full fontanelle or abnormal eye movements. They might be hypotonic or hypertonic. As far as cardiovascular signs or symptoms, they might be pale or gray. They might have cyanosis, mottling. They may feel cold or clammy. They might have tachycardia or arrhythmias, or hypotension and edema. Respiratory-wise, they may display apnea, tachypnea, cyanosis, grunting, or irregular respirations. In the GI system, they might have poor feeding, vomiting, diarrhea, or abdominal distension. Their belly might become hard or loopy. Their skin might have petechiae. And then as far as determining between bacterial versus viral, bacterial infections often present with rashes, pustules, umphalitis, purpura, scleroderma. Viral infections often include jaundice, purpura, scleroderma, and a vesicular rash. So now I'll talk a little bit about basic hematology and some lab interpretation. We'll go over it. A CBC with differential, a blood gas, BMP, CRP, and then blood cultures. So this is a typical CBC with differential. This usually is indicated to assess for anemia, thrombocytopenia, which is low platelets, and to help evaluate for sepsis, although it's not very specific to sepsis. It'll have your white blood count, your red blood count, hemoglobin, hematocrit, platelet count, and then your differential blood cells, such as your neutrophils, lymphocytes, monocytes, eosinophils, and basophils, and then your absolute neutrophil count sometimes is included on there. As far as interpreting the CBC, preterm infants, or I guess any infant, there's a kind of a wide range of normal hematocrit from 40 to 65%, which coordinates to a hemoglobin of about 14 to 20. This is used to evaluate the percentage of red blood cells in the full blood volume. And it's important to keep in mind that the lifespan of red blood cells in the neonate are much shorter than those in adults. In preterm neonates, red blood cells circulate for about 35 to 50 days. And in the term infants, they have a little bit longer lifespans of about 60 to 70 days. And in adults, it's usually typically about 100 to 120 days that they circulate. As far as platelets, The normal ranges are anywhere from 150,000 to about 400,000. Platelets help with hemostasis and clotting. Thrombocytopenia is considered platelets less than 150,000, which is usually abnormal and should be investigated. And it can be a late sign of infection, although there's several other causes. The white blood cell count in preterm infants is typically a bit lower than in term infants, which from about 6,000 to 19,000. Term infants, it usually runs about 10,000 to 26,000. And it's important to keep in mind that a lower white blood cell count, so neutropenia, is often indicative of a worse infection and a higher white blood cell count. So the CBC with DIF measures all white blood cell types, which are the infection-fighting cells. Your granulocytes are your neutrophils, basophils, and eosinophils. The neutrophils are phagocytes. They ingest and destroy small particles such as bacteria, protozoa, cells, and their debris. Immature neutrophils are bands, myelocytes, metamyelocytes, promyelocytes, and those are increased with infection. Your bone marrow releases more to the bloodstream to mature and fight infection as the mature ones are being used up by the infection. Basophils are often involved in allergic and inflammatory responses. And then eosinophils are similar to neutrophils in function, but less effective in their response, and often present in allergic and anaphylactic responses or parasite destruction. And then your monocytes are your immature circulating macrophages. They're like the cleaners. They clear old blood cells, cellular debris, and opsonize bacteria for destruction. And those are also increased after infection. And then your lymphocytes, there's two types. Your T lymphocytes, which originate from your thymus, and your B lymphocytes, which originate from your bone marrow. T lymphocytes are involved in graft versus host disease, delayed hypersensitivity reactions, and B lymphocytes produce and secrete immunoglobulins and antibodies. So the CRP, these are other things that you can look for when you're evaluating for infection. The CRP is the amount of protein in the blood signaling an inflammatory process. It rises with sepsis, and it's usually good to trend the CRP to look for a rise or a fall. It usually returns to normal within 2 to 7 days following adequate treatment of infection. The ANC is the absolute neutrophil count. In order to calculate your ANC, you take your white blood cell count times your percent of immature and mature neutrophils. And an ANC less than 1,500 is predictive of infection and a decreased ability to fight off infection. Less than about 500 to 1,000 is significant of severe neutropenia. And a lot of time, kids with a low ANC will be put in protective isolation so that we don't expose them to any more risk of developing an infection because they don't have that ability to fight things off as well. And then blood cultures are obtained when evaluating for sepsis, since it's the gold standard for diagnosing sepsis, a positive blood culture. A positive blood culture signifies the presence of bacteria in the bloodstream. It's important to collect at least a minimum of 1 ml of blood using sterile fashion with venipuncture or arterial puncture to obtain the blood culture specimen. And blood cultures usually grow out for about 5 days. I think they're read out final after about 5 days. So if they turn positive anytime between day 1 and 5 of collecting them, then as long as they're not determined to be contaminants, then we treat those positive blood cultures. And then the R to T ratio is the immature to total neutrophil ratio. An increase in immature neutrophils increases the I to T ratio, which is also called a left shift. A ratio greater than 0.2 is suggestive of infection and has about a 90% sensitivity for infection. So here is an example of a normal blood gas value. We want neonates to have a pH between about 7.35 and 7.45. Their CO2s, this would be an example of an arterial values that we would want. The CO2 typically between 35 and 45, although especially in preterm infants, but sometimes late preterm infants, we allow what we call permissive hypercapnia. So we allow their CO2 to be slightly higher and their pH to be slightly lower than the normal range at the expense of protecting their lungs from barotrauma and volutrauma with mechanical ventilation. And then the O2, we want 80 to 100. And then the bicarb level, the normal range is 22 to 26. And then the SaO2 would be about 88 to 100%. Oh, and I also wanted to mention that these are the arterial ranges, but a lot of times we will not check arterial blood gases if they don't have an arterial line in place. So in that case, we're often getting venous or capillary blood gases. And your venous and capillary blood gases are going to have slightly higher CO2s, and your O2s are not going to be reliable because it's deoxygenated blood. So they're going to be much lower O2 values, which aren't going to have much meaning for you, and your CO2s will run a little bit higher. So here is a basic metabolic panel, or a BMP, and I also put on here a magnesium, which is actually ordered separately. It's not included on most BMPs, but I just wanted to include it here to talk about it a little bit. Normal range for sodium in babies is 135 to 145. Oftentimes, the first 2 days of life, when they haven't diuresed yet, your sodiums will run a little bit lower, and then that third day when they start diuresing, your sodium will increase and sometimes even be on the higher end of normal, like 144, 145-ish. And then it'll kind of, with feedings and or IV fluids, it'll kind of stabilize out after that and normalize. Potassium range for normal is 3.5 to 5.5, and oftentimes if we are obtaining a capillary sample from a heel stick, we can cause the potassium to be a little bit hemolyzed, which will elevate the level and not be so accurate. So if you have an unexpectedly elevated potassium level, it's wise to check it and confirm that with a venous draw or an arterial draw, just to make sure it's a real value or not a real value. What happens is when we squeeze babies' heels, we hemolyze those red blood cells and potassium leaks out and causes a false elevated serum potassium. And then the chloride level for infants is 98 to 113. Your CO2 should correlate to your bicarb on your blood gas. So sometimes it's a little bit lower, but usually 20 to 22 to 28 would be your normal range. And then your BUN and creatinine. Your BUN can be reflective of kidney function, but also hydration status. So if you're dehydrated, it might run a little bit higher, and some babies who are protein deficient, the BUN will actually run low. And then your creatinine indicates kidney function. Usually in late preterm infants, it'll run a little bit higher, like closer to the 0.8, 0.9 to 1 in the first few days of life, and then it'll naturally decrease over the first week of life with improved glomerular filtration rate and kidney function. And then calcium levels. Calcium is acquired mainly in the third trimester, so the earlier the infant, often the less calcium they'll receive from mom in utero, and they will have low calcium levels, usually which are transient in the first few days of life. So sometimes they might run about 7 to 8, and then they usually start to increase after those first few days of life, especially when we start giving them IV calcium or calcium in their feeds. So a normal range is usually 8 to 11. And then if it's elevated, it's often caused by us giving them calcium. And then your normal glucose ranges is about 45 to 50 up to 110. Usually in the NICU, we don't treat glucose hyperglycemia unless their blood sugars are running 200 to 250 or greater. But in normal late preterm or term infants, we don't usually see blood sugars that high. And then for magnesium, we'll often check that for kids whose moms were on magnesium before delivery because it can run a little bit high. It usually just, there's not much we do about it. We'll check it on day 2 or 3 of life, and if it's elevated, it'll just go down naturally with time as they eliminate it. And just the thing to be aware of with kids whose moms are on mag is just the potential for them to have some respiratory depression and hypotonia after delivery. So that pretty much concludes my presentation. I thank you all for taking the time to listen, and I hope that you learned something from this that you can take as you practice and work with the late preterm population. I hope you have a great day, and please reach out if you guys have any questions. Thank you. And here is a list of references, especially if you guys want to go back and look at any of this information or read in some more depth. These are some good sources.